PercuTrach, set for percutaneous dilatation tracheostomy. In intensive care, percutaneous dilatation tracheostomy is an established standard procedure. During longer-term ventilation of intensive care patients in particular, it is increasingly preferred over traditional intubation. There are good reasons for this. Dilation can be performed gently and at the bedside in ICUs. Unlike with intubation, the patient can take in food orally during ventilation. Using speaking valves, it even allows speaking, and oral and bronchial hygiene become much easier. In addition, the tracheostoma created by dilation spontaneously closes after treatment has been completed. Dilatation tracheostomy, according to Cannula, is the method used most frequently during this type of treatment. Our PercuTrach PDT set allows this minimally invasive technique to be carried out simply and safely. It offers the ideal combination of a dilation set and various tracheostomy tube versions that are perfectly matched to the set. Each tube version is supplied with an Atraumatic inserter. The latter features a specially designed handle with incorporated protrusions, which guarantees secure handling. Each inserter is matched to the specific tube size. It snaps securely into the outer cannula. This ensures a precise transition to the tube tip, which permits atraumatic insertion. To use the PercuTrach PDT set, first prepare the patient. After the patient has been sedated, place him in a supine position and support the neck and shoulders in such a way that the neck is hyperextended. An ultrasound exam of the neck region is recommended to specify the anatomical conditions. Disinfect the skin and cover the area around the neck with sterile dressing. After palpation of the thyroid cartilage, markings for the incision area are recorded based on anatomical landmarks, the tracheal rings and the jugulum, to improve orientation. The patient is typically punctured between the second and third or the third and fourth tracheal ring. Now the bronchoscope must be adjusted to prevent the cuff from being pierced in the process. The completely deflated endotracheal tube is pulled until just below the vocal cord level. Here it is re-inflated again. For hemostasis, a local anesthetic should be injected. Now a 1.5 to 2 centimeter long incision is made in the tracheal gap, and a blunt preparation of the trachea is performed. Now insert the puncture cannula with the catheter attached into the insertion site. Correct positioning can be checked by aspirating air bubbles using the attached syringe, which is partially filled with saline solution or sterile water. Then slide the puncture cannula out of the catheter and withdraw cannula and syringe, leaving the catheter in place. A kink-resistant Seldinger guide wire is now inserted into the catheter. To do so, first straighten the J-tip of the guide wire by using the dispenser and make sure that the tip does not protrude. Attach the dispenser to the catheter and feed the guide wire into it. It should pass easily with no resistance. The wire can be pushed forward in caudal direction until the first dark marking on the wire reaches skin level. Once the guide wire has been positioned, the dispenser can be removed, followed by the catheter. Now advance the short predilator over the guide wire and carefully dilate the puncture site with a slight twisting movement. Here the predilator should be tilted towards the cranium to avoid damaging the rear wall of the trachea. Prior to the next step, the hydrophilic coating of the dilator must be activated with saline solution or distilled water. The dilator with inserted guiding catheter is threaded over the Seldinger guide wire until the safety lock of the guiding catheter reaches skin level. In the process, the proximal marking of the wire must become visible. By pushing forward and back several times, the tracheal opening can now be dilated until the marking 38 French is visible in the tracheal lumen by using the bronchoscope. Next, the dilator is removed. The guiding catheter and Seldinger guide wire remain in the trachea. Now the corresponding tracheostomy tube can be inserted. To do so, insert the atraumatic inserter into the outer cannula. The cuff, which has been checked for leaks, must be completely deflated and coated with the supplied lubricant to ease insertion. Via the guiding catheter and Seldinger guide wire, the ProLine tracheostomy tube can now be inserted into the trachea using the atraumatic inserter. First, up to the guiding catheter's safety lock, then together with the guiding catheter and guide wire until the tracheostomy tube flange has reached skin level. Next, the atraumatic inserter, guiding catheter and guide wire are withdrawn together in an arc movement. The included inner cannula can now be inserted to ensure a free airway. The trachea and tracheostomy tube should be suctioned. Then the breathing circuit with the attached bronchoscope can be switched to the tracheostomy tube, and at the same time the position in the trachea can be checked. Now the cuff can be inflated. Before the endotracheal tube is finally removed, the trachea and position of the cuff should be rechecked via the tube by using the bronchoscope. If the tracheostomy tube is positioned correctly, a tracheal compress should be used and a neck strap applied for fastening. It is a good idea to check the cuff pressure with a cuff pressure gauge and to take an X-ray of the thorax. The PercuTrach PDT set for stepless dilation is available in various versions. The dilation set can be combined with a ProLine tracheostomy tube. Cuff. Cuff voice. Suction. Suction voice. Visit our website or contact us for more information. Thank you.